It is a great pleasure to welcome Dr. Sunil Rajan, Professor of Amrita Institute of Medical Science, Kochi. He is the faculty in Head and Neck Division of Department of Anaesthesia, Amrita Institute since 2005. His area of interest include difficult airway and research. This session will be moderated by Dr. Arjun, Associate Professor of Dr. Mupin's Medical College, Wayanad, and Dr. Deena Dayal, Consultant and Anesthesiologist of Government Hospital, Kainati.
The topic of my talk is anesthetic considerations for the laryngeal laser surgery. It's okay. As we all know, the laryngeal laser surgery offers enhanced precision during surgical procedures, and it minimizes intraoperative bleeding. It also improves therapeutic outcomes for vocal fold lesions, and is commonly used for treating malignancies like papilloma and polyps. But however, it requires a close coordination between the anesthesiologist and the surgeon. Preoperative evaluation is of prime importance, and a detailed pre-op assessment is required to identify the medical conditions of the patient and the airway assessment. And you should review all the available radiological images of the airway, mainly the CT and the MRI. And the most important thing is the pre-op flexible nasal endoscopy, which is crucial for assessing the characteristics of the lesion and which will decide your airway management to a great extent. This helps to determine the degree of airway compromise before surgery and also aid in planning the best airway management strategy. These are the laser types used in laser surgery, but the common ones we use are carbon dioxide laser and KTP lasers. A few things about carbon dioxide laser. It's used to treat benign laryngeal lesions like polyps, papilloma, webs, hemangioma, subglottic stenosis, and also for atenodectomy. This offers precise cutting with shallow tissue penetration. Different modes are available like continuous pulsed and super pulsed modes. The advantage of using a super pulse mode is that it minimizes thermal injury by allowing tissue cooling between the pauses. About KTP laser, this is strongly absorbed by hemoglobin and melanin, so it's suitable for vascular lesions and is effective for otolaryngeal lesions, hemorrhages, and airway vascular diseases. The advantage is that it has a precise targeting and it minimizes damage to surrounding tissues. It's commonly employed to control bleeding during surgeries. So we'll come to the airway management strategies for laser surgery. Usually the preferred technique is endotracheal intubation as far as possible. But sometimes we may require a tubeless technique like apneic intermittent ventilation, and jet ventilation is also required. These two actually the newer options like high flow nasal technique and Thrive. All these offer a tubeless technique and unobstructed surgical fields. A word about laser tubes. These are designed with metallic wrapping for laser resistance, and the cups are usually filled with saline, especially with methylene blue to indicate punctures. Smaller tubes to be used, usually the tubes with internal diameter 5 to 5.5 millimeter will be used for optimal surgical access. The reflective metallic surface reduces the risk of laser induced fires when we are using these tubes. The commonly used tubes what we have is laser flux, laser tubus and laser shield. Laser flux has a double cuff. Usually the proximal cuff is filled with methylene blue. Laser tubus also has two cuffs, but this is a cuff inside cuff type tube. Laser shield has a single cuff, but it's usually filled with methylene blue. So the ease of understanding, we can divide the surgeries into supraglottic, glottic and subglottic. So first we will talk about the supraglottic lesions. Oral intubation with a laser tube is usually preferred, and the intubation technique depends on the site and size of the tumor and the patient symptoms. The intubation can be awake or under general anesthesia. Suppose the patient has a stridor, and here the pre-op assessment of the airway with nasal endoscopy come into play. Suppose you think that there is a big swelling there and which is almost obstructing the glottic view, better you go for a awake intubation. Suppose there is a partial obstruction only and you think that there is enough space to pass a tube, you can induce and do a video laryngoscope assisted intubation or a awake bougie guided intubation can be done. About vocal cord lesions, the cord lesions near the anterior commissure, the intubation is acceptable as the tube can be pushed away from the field with the suspension laryngoscope during surgery. Whereas in posterior glottic web and lesions near the posterior commissure, a tubeless technique is usually preferred. For procedures like Kashima and cordotomy, here the procedure will be done near the posterior part and a tubeless technique is usually asked for. Or if the endotracheal tube can be pushed away with the suspension laryngoscope, the tube can be retained. Subglottic laser surgery, actually most of these patients will come to you already tracheostomized because the patient will be having a subglottic obstruction, and because of stridor, patient will be mostly tracheostomized. So a tubeless technique is usually preferred if there is already no tracheostomy. Actually, the problem with subglottic laser surgery is that the location is not optimally accessible with endoscopic laser technique, as the tumors can extend beyond the reach of the laser and making the complete removal difficult. And there is a risk of subglottic stenosis as well. The indications include small tumors, palliative debulking, subglottic hemangiomas, and also to excise scar tissue in subglottic stenosis. In the image, the first image, you can see a subglottic stenosis, and the lower down image, the stenotic part is excised using laser. Now, about ventilation strategies. Mostly, if there is a tube, if you can do the surgery with the tube, well and good. It's a routine surgery almost. But a tubeless technique, the most commonly used for laser is apneic intermittent ventilation. Here we provide an unobstructed access to the surgical field, and the patient immobility has to be ensured with neuromuscular blockers. Here the ventilation is intermittently controlled to allow gas exchange, and the endotracheal tube is removed periodically and reinserted. For this, you need not have to use a laser tube. You can use a small normal endotracheal tube or a MLS tube, which is passed through the suspension laryngoscope whenever the SpO2 falls below 92. Actually, it's 92. And the problem is that the surgical pace is disrupted and it has a low airway vulnerability. It's best suited for short, uncomplicated procedures. The tubeless technique, jet ventilation, I think Suvarna has already covered most of it. Jet ventilation delivers high pressure gas through a small bore cannula or a catheter, and it results in inspiratory flow with a passive inhalation, which can be delivered through a supraglottic, infraglottic or tracheal route. And total intravenous anesthesia is required since the inhalation agents cannot be used. The advantages include we provide an unobstructed or minimally impeded surgical field and surgical access, and the surgical field is relatively still. However, for the control of patient immobility and vocal cord movement, neuromuscular blockers has to be used. With newer automated jet ventilators, we can control and monitor FiO2, EtCO2, peak airway pressure and PEEP, and it is suitable for prolonged and laser procedures. The disadvantages include there is a sole dependence on intravenous anesthesia, there is a risk of barotrauma, and we need automated jet ventilators for safe use, and significant experience is required for the safe use. and it is not suitable for patients with significant pulmonary or cardiovascular disease. The newer laser tubes available are Hunsaker mount jet ventilation tube and laser jet double lumen tube. Both are laser resistant tubes. They come with a metal fillet to aid tracheal placement. It has two ports, a large port which is used for jet ventilation and a smaller port for monitoring the distal airway pressures and respiratory gases. These tubes are not available in India now. Other methods of providing tubeless technique of ventilation is high frequency nasal oxygenation and Thrive. They deliver humidified oxygen rapidly for ventilation exchange and provide unobstructed surgical fields for during the procedures. The risk is that it provides a higher oxygen concentration which may increase fire hazard during laser surgeries. The role of muscle relaxants, it provides a motionless surgical field and it's critical for ensuring mobility and precise surgical manipulation. Usually short-acting agents like succinylcholine, or if when you are using rocuronium, Sugammadex may have to be used. So I'll move on to the general precautions against laser hazards. Eye protection. Always remember that direct or indirect laser exposure can cause serious eye injuries, and you should use wavelength specific goggles to prevent eye injuries. The exposed skin of the patient should be protected with saline soaked towels or drapes, and the patient's eyes should be protected with saline soaked pads or metal goggles, and should avoid petroleum based eye lubricants. The most dreaded laser hazard is the airway fire. So for airway fire to arise, it should fulfill the fire triad. That is the ignition source, that's a laser. Fuel is usually our endotracheal tube or a gauze or usually a gauze piece, something like that, or oxidant, that is oxygen. Usually unprotected tubes disintegrate under laser impact, igniting flames, and the risk increases with oxygen-rich environments in anesthesia circuits, and the prevention is with use of laser-resistant tubes and saline-filled cuffs. About the airway management during airway fire, you should immediately stop the airway laser activation. The anesthesia circuit should be disconnected and remove burning fragments. Rapidly remove the burning endotracheal tube and debris from the airway. Extinguish saline or water. And after that, you reevaluate the airway using a flexible bronchoscopy or a direct laryngoscopy. And based on your findings, you can decide on reintubation or use of a supraortic airway device or ICU management. Laser plume hazards, generated smoke contains harmful fine particles and may even contain viral DNA from the vaporized tissue. And so smoke evacuation system should be properly positioned and functional. Pneumothorax, the main reason is barotrauma during jet ventilation, and obstructed upper airway can increase the driving pressures, increasing the risk. Management range from placing a ICD tube and or close observation depending on the degree of pneumothorax. Bronchospasm, it's usually due to airway irritation when the patient is in an inadequate depth of anesthesia or when the patient has an underlying asthma. Management is usually by deepening anesthesia plane or administering bronchodilators. Surgical emphysema usually result when there is an inappropriate driving pressures during ventilation or when laser strikes below the carina causing submucosal flap separation. These patients should be monitored closely postoperatively, and prompt recognition ensures effective recovery. Laryngospasm, you encounter laryngospasm mostly during tubeless surgeries, typically caused by airway irritation or insufficient anesthesia duct. Management is deepening the plane of anesthesia, or sometimes even neuromuscular blockage will be required. The common post-op complications are bleeding and airway edema. Airway edema can lead to obstruction requiring immediate intervention. Bleeding may result from injury or surgical manipulation. So hemostasis should be ensured before completing the surgery. Vocal cord paralysis can result from the surgical manipulation or nerve injury, and pulmonary aspiration of the surgical debris is also possible. So in general, postoperatively all these patients will be given IV steroids unless contraindicated, and adrenaline nebulization. This person will be nursed in propped up position and with a close monitoring. So this is just two cases. This is a supraglottic tumor for a laser excision. Here the patient, the first one, the patient had a big supraglottic mass which was sitting in front of the glottic opening. We opted for a fiber optic intubation. You can see the glottic mass, this supraglottic actually. We used a fiber optic and went by the side of the tumor, and there you can see the vocal cord, and lower down the trachea is visible, and patient was intubated like that. It was a oral intubation. In the second video, actually it's a procedure. You can see the laser being used to excise the supraglottic lesion. Here the tube was retained and surgery was done. Okay, you can just see the steps of the laser resection. In this, it's a patient with a posterior commissure lesion excision. Here, the surgeon demanded a tubeless technique. So, it's just the procedure being done, and behind the screen behind, you can see the resection being done. This is the glottic view. You can see the lesion near the posterior commissure, and you can see the glottic opening, and there is no tube there. So here what we do is we just wait till the saturation drops below 95. Actually, we usually wait till the saturation drops below 90. Then an endotracheal tube is passed through the glottic opening. Okay, now we have paused the laser surgery, and endotracheal tube is passed through the suspension laryngoscope, and which is connected to the breathing circuit, and the patient is ventilated. So quickly go through the safety measures. The pre-op checks, always use wavelength specific eye protection. Laser and usage signage should be put in front of the OT, and the window covering should be opaque. Should always use a laser resistant endotracheal tube or wrapped endotracheal tube with aluminum or copper tape without gaps. Always use saline filled cuffs, and wet towels or gauze should be placed to cover the patient face, and fire extinguisher or water source should be available, and laser settings should be confirmed before use. Intraoperative safety protocols include always use FiO2 less than 30, avoid nitrous oxide. Laser should be on standby mode when not in use, and laser activation should be done only by the surgeon, and always keep the tip of the laser visible, and smoke evacuation system should be active. The most important is the role of interdisciplinary communication. A seamless coordination between the surgeons and anesthesiologists is vital in these surgeries, and as shared airway access demands synchronized team efforts. Discuss preoperative assessments and plan strategies together, and collaborative teamwork enhances patient outcomes. To conclude, anesthetic management of laser laryngeal surgeries demands extensive planning and preparation. Collaboration between surgical and anesthetic teams is vital for patient safety. Strict adherence to laser safety protocols minimizes complications, and comprehensive post-op care ensures optimal recovery. These are my references. Thank you.
Thank you, sir, for the wonderful presentation. As sir has told, the anesthesia for laser surgery often presents with unique anesthetic challenges, as we have to manage a shared airway. We have to take precautions, like we have to mitigate in case of fires, and also precise ventilation strategies are needed. And above all, we should have a thorough preoperative assessment of the airway to plan our management. And this is really a critical area where the surgical precision meets with the anesthetic vigilance. So thank you, sir, once again for a wonderful presentation.
Thank you.
Thank you, sir, for the presentation. Actually, I have not done a procedure like this. Like in my real life, I have not done, administered anything like this. So I would like to know what is the patient selection choice? Like, will he choose for all patients?
Actually, the patient selection is done by the surgeon.
Okay.
They bring,
we
if
have
they
got
bring
our
for
own.
laser surgery, we have to give anesthesia like
Okay.
that.
So we can't, I mean,
No. I think very big tumors and malignant tumors which are extending below the, supracortic tumors extending even below, these cases won't come for laser surgery because they will go for a laryngectomy. So reasonably smaller lesions will only come for us. Our main challenge will be in case of supracortic airway, the intubation will be a real challenge for us. Then the real challenges will be managing tubeless anesthesia.
Okay. Sir, is there any difference in the outcome if you are using conventional and laser? Have you observed something?
I think laser, conventional, I think laser surgeries.
My question is because we are more towards laser, right? Is it being forced upon or like is there?
No. The patient outcome will be better because there will be less bleeding, morbidity will be less, surgical time will be less. Overall, the patient outcome will be better if you go for a laser surgery.
Okay, thank you, sir, for your wonderful insight. I hope like the session was especially useful for the PGs because this topic will be presented for almost all the exams. Yeah. Thank you, sir.
Thank you, sir. Thank you, ma'am. Now I invite Dr. Arjun PS onto the stage to felicitate Dr. Sunil Rajan. Now, I request Dr. Arvind to kindly come to the stage to felicitate Dr. Arjun PS and Dr. Deena Dayal. Yeah.